Next to the podium, we have Dr. Amar Bansal, completed his medical school at NYU and postgraduate training in internal medicine and nephrology at the University of Pennsylvania. He had a long interest in laboratory science and was involved in bench research until 2015. His interest in serious illness, palliative care, and end of life led him to pursue a palliative care fellowship. He is now assistant professor of medicine at the University of Pittsburgh, where he is active on both nephrology and palliative care services. He has clinical and research interests in renal supportive care, onconephrology, and dedicated clinics for both. Please come to the podium.
Thanks for having me. I'm really honored to be here. Palliative care doctors need a warning before that kind of a beautiful and brave talk. I'm still kind of getting myself together. I can't imagine how rough that was for you. So thank you for your bravery and your courage for sharing your story with us. The title of the talk now seems quite presumptuous, actually. So I'm going to actually try and share with you the experience of kidney disease from the other perspective, from how research informs much of what Margaret just shared with us. No disclosures, and one thing you should know is that I'm also a palliative care physician. So a lot of the perspective that I'm sharing today comes not just from me being a nephrologist, but also being a palliative care doctor. Learning objectives, really to describe the symptoms, many of which we just heard, that kidney patients face, understanding how patients with kidney disease really truly have unmet palliative care needs, and discussing how we can incorporate some palliative care principles into our field so we can improve kidney care overall. And this is how we're going to structure the time today. We're going to talk about current trends or sort of current epidemiology of kidney care. We're going to focus on what I think are some of the concerning aspects. And much to what we just heard, what are patients and families and caregivers saying about this experience as they go through it, sometimes for months, sometimes for decades, and how we can do better overall. So I'm going to skip over chronic kidney disease and end-stage renal disease. I'm going to go straight to the definition of frailty, which comes up again and again in this talk. And there's no perfect definition for frailty, but one that I like is having a combination of biomedical factors that reduces someone's ability to withstand environmental stress. And if you'll notice, age is not a part of this definition. So you can be young and be frail, or you can be elderly and be frail. So try to keep this in the back of your mind as we go forward and talk about some of the things this morning. Epidemiology, basic things that we've already heard from other speakers. Chronic kidney disease affects 14% of all Americans. African Americans are disproportionately affected by kidney disease. And about 500,000 patients are on dialysis in this country at any given time. And some things that might come as a bit of a surprise to you are that adults older than 75 have the highest rates of dialysis initiation in the U.S. More than half of dialysis patients in this country are 65 or older. Now, I call this epidemiology 2.0 because I'm expecting some minor amount of surprise to some of these facts. So survival with end-stage renal disease is comparable to many malignancies. Nursing home residents on dialysis have a 50% one-year mortality. About half of our patients who are on dialysis have some form of cognitive impairment. And at least 1/3 of our patients who receive dialysis are frail. And this is also very interesting. This is data from NHANES, which is a large epidemiologic survey, which shows how many people that carry a diagnosis of chronic kidney disease, depending on stage, which I'm not sure if the colors are projecting very well, but stages 1, 2, and 3, if you look, across time for the past 10 or 15 years or so, less than 10% of patients who have chronic kidney disease stage 1, 2, or 3 are not aware that they had that diagnosis. And of the individuals who have stage 4 kidney disease, less than half of them are truly aware that they actually have kidney disease. So it's a silent disease. It's often asymptomatic. And then we'll come to when it transitions from being asymptomatic to being symptomatic, what that exactly looks like. And if that wasn't concerning enough, that's kind of the lay of the land. What I want to actually shift gears now is talking about what I think are concerning aspects of kidney care, because I think these are things we can actually truly modify. These are not necessarily technological limitations or limitations related to a lack of access to transplant or not even necessarily disparities related. These are issues that I think we can actually do better as a community with. So concerning areas, high symptom burden, we have an inadequate discussion of patient and family preferences, and our patients have a very intense end-of-life experience. So high symptom burden, what does that look like? Over half of dialysis patients experience these three symptoms: pain, fatigue, and pruritus. And what's fascinating about the transition, and we've heard a lot about transitions today, is the fact that when you transition from having chronic kidney disease to having ESRD, there isn't a huge appreciable difference in the quality of life or the symptoms that patients feel when they go from advanced CKD to having ESRD. That is kind of a loaded statement, and would love to discuss that later. Certainly, uremic symptoms do get treated very effectively, and patients often feel dramatically better. But when you look at this from a big picture standpoint, sort of the 30,000-foot view that Sean shared with us earlier, that's when this statement sort of rings true. And it's kind of ironic because we often refer to dialysis as renal replacement therapy, and it's not really a replacement at all because these symptoms are not often changing in any kind of a dramatic way for many patients. If you lower the bar a little bit from half or 50% of patients to 40% of patients, that list really expands to all these symptoms. And what's troubling is not just the fact that patients experience these symptoms, but we as nephrology providers are often unaware of these symptoms very often. And moving beyond physical symptoms, this is something that we just heard about from Margaret quite poignantly, is the fact that it's not just physical symptoms, it's impaired quality of life. You have medication side effects, you have illness effects, there are issues with psychosocial support, and often functional decline occurs with dialysis, especially if someone is starting dialysis and they already have advanced age. So I want you to sort of think about this as we move forward, especially if you're a provider, because certainly patients can experience this firsthand, but as providers, I think we should really be much more aware of this. And so the role really becomes, how do we help our patients make decisions? And how do we do a better job of presenting choices to them that make sense, that are presented in language they can understand, and also result in a choice that's consistent with their values and preferences. And so I invite you to think about an analogy where you're sitting at a restaurant and you ask the waiter, what's good? One kind of waiter might say, everything's good on the menu. I like it all. The other guy might say, you know what? Do not get the chicken marsala. It is not good. You guys can have your own preferences. I prefer the second kind of waiter. I prefer if somebody's honest with me, even if they whisper it in my ear, I much prefer this kind of waiter on the screen. So I'm not trying to trivialize the decisions that we make, and with this analogy, I'm trying to impress upon you the role we have as patients to ask better questions and as providers to give better feedback. And so I want to put this down in some numbers and talk about what exactly patient preferences mean and what those look like. So this is not perfect. This is a slide that shows on the horizontal axis different ways patients can express their wishes. So we have advanced directives, we have treatment preferences, we have the identification of a surrogate decision maker, and those are all listed at the bottom. On the vertical axis is the percentage of patients who passed away in the study who had these things identified in their medical record. And the shades of blue are a little bit difficult to project, but dialysis patients are the darkest bar on the left of each group. And other serious illnesses like cancer and severe COPD and advanced dementia are the other categories. So in every single category, our patients have the lowest percentage of these items documented in their charts. So I'm not going to point fingers at all during this session. I'm just going to lay out the facts for you and show you how we can do better. And really the question is, well, why does this matter? Maybe we're having fantastic conversations with our patients, and the fact that these aren't documented in their chart doesn't really matter. It turns out that it really, really does matter. And this is a figure from the same study that shows that when you have both a surrogate present in the chart and some sort of treatment limiting directive, and those categories are shown by the darkest box, when you have both present, you decrease the amount of hospitalization, you decrease the amount of ICU care, of intense procedures, and the chances of a patient dying in the hospital, and you increase hospice use when appropriate, and you increase this idea of discontinuing dialysis if the patient, expresses a desire to stop dialysis. And if you look at the lightest bar, when just a surrogate is present, just something as simple as a surrogate decision maker, you still see some durable effects from that. You still see positive changes in each of these categories. And so the next question is, well, maybe we're doing better. This data exists, and we're already doing a better job sort of addressing some of these issues. Unfortunately, the answer is we're not. This is one of my favorite studies that looks at how this landscape has changed over 10 years. The light bar is 2000, and the darker bars are 2010. And you see stone cold, pretty much the same across the board over 10 years. So we as a community, we as a culture, we're having difficulty engaging our patients in difficult conversations. And maybe patients have a hard time discussing this with us. It could be a two-way street, but either way, this is a two-way street that we need to kind of look at and stare at and acknowledge. This naturally leads to an intense end-of-life experience for dialysis patients. Some of you have seen me share this slide already, but I'm going to share it again because I think it's very important. This is a study done by Susan Wong, and what it shows is basically how the last month of life looks for dialysis patients when you compare them to patients who have cancer or heart failure. So the idea being that these are not the same, these are different diseases, but they're all pretty serious conditions. So it's kind of the best comparison we can come up with. And here we see that dialysis patients are hospitalized more and for longer. They have more ICU stays, in fact, almost double than cancer patients do. They spend more time in the ICU. They get more intensive procedures, which includes mechanical ventilation or CPR, than cancer patients do. They use hospice at much less of a rate than cancer patients do, and they often die in the hospital much more commonly than patients with cancer. So now I'm trying to remain true to the title of the talk, and I'm trying to shift away from this outside-in perspective and looking from the inside out now. So there is research being done that has been done on some of the things that Margaret shared with us about what exactly does the patient experience look like. So I want to shift perspectives now and talk about that. So patient perspectives. This is a great study done by my colleague at Pittsburgh, Jane Schell. And it was done basically looking at a handful of patients, about 30 patients, who all had to be over 65 to be part of the study. And basically they did structured interviews and tried to identify themes from these patients of what their experience was like leading through their illness trajectory, meaning leading through their time on having CKD up until when they started on dialysis. And what was fascinating about this is that they also decided to include some nephrologists. About 10 nephrologists were included in this study. And what did they find? So we heard sort of very, very poetically about all these themes that patients felt. Patients were often shocked by their diagnosis. It came as a surprise. Patients expressed the second theme of being very uncertain about their future. And they felt very unprepared for dialysis when dialysis started. Nephrologists, interestingly, and I'm not making this up, had 3 themes that essentially correlated with each of the patient themes. And I found this to be really beautiful work. Nephrologists had said that they struggled to explain the complexity of illness to their patients. Nephrologists themselves felt a lack of control over the disease. Maybe this was a patient with diabetes who never took insulin. So the nephrologist felt, well, what is my role? What can I do to help this patient? I can't go home with them and make them take their insulin. Nephrologists also felt themselves avoiding discussions about the future. So I've put these here sort of next to each other because you can see how they play off of each other and how this sort of emerges as a pattern in kidney care. This is probably too small for most of you to read, but it goes through really nicely in graphic sort of format what patients and nephrologists are feeling throughout their illness trajectory with these themes. And it really just drives home the point that we need better communication throughout the course of kidney disease. And again, some of you have seen this slide. It's one of my favorite studies as well. And it really drives home the point about why preferences truly matter. Why asking somebody, do you prefer A or do you prefer B? Why that really matters. So this is a study that was a national survey of over 600 nephrologists. And nephrologists were asked the question, if your kidneys failed and there was a sort of typical waiting time for a transplant, what would you want? What kind of dialysis would you want? And the white part of this pie chart is basically some sort of home dialysis. So the vast majority of nephrologists wanted this kind of care. What's actually happening in the U.S. is pretty much the exact opposite. I am not saying this is the nephrologist's fault. This is a complicated phenomenon. But what I'm saying is that this is very interesting and that patients are not getting the kind of care that the experts themselves would want if they had kidney failure.